Today's webinar is statewide hospital outcome data. We are very happy to have Josh Legler, who's EMS Data Consultant to the NEMSIS TAC, and Brenda Clotfelter from the Florida Bureau of Emergency Medical Oversight. And they're going to be talking to us about leveraging HIEs. This is all of this information. It's great work and passion of both of them. So I'm excited for this information. And yeah, further ado here, I will just hand over the time. Josh, go ahead and take it away.
Thank you, Chris. Great to be with you all today. I'm excited to be able to host Brenda Clotfelter from the Florida Bureau of Emergency Medical Services Oversight to discuss how they've integrated their EMS data system at the state level with their state health information exchange, and they're getting outcome data on a bunch of EMS records. So the majority of today's presentation is going to be done by Brenda, just sharing what they did, how they did it, how it's working, and how they're using the results of their work there in Florida. But I'm going to start out with a little bit of kind of preface material here to kind of set the stage for interoperability and data integration with EMS. When we talk about interoperability between EMS and the rest of healthcare, we can kind of boil it down to these kind of basic steps or pieces. One is when EMS responds to a patient, interoperability would give EMS the ability to access some information that already exists about that patient from other healthcare providers. So they would know the patient's medical history and things like that. Interoperability also allows EMS to share their report with the hospital when they take the patient to the hospital. And then this third step, interoperability should allow EMS to know the hospital outcomes of the patient that they took to the hospital. What were their diagnoses? What was their discharge disposition? How long did they stay in the hospital? Things like that. Now, this is a very basic boiling down of interoperability. In reality, there's all kinds of nuances and details. For example, EMS could be sending EKGs or alerts to the hospital. EMS could be getting advanced directives from the network. All kinds of stuff could be going on, but it kind of boils down to these three steps. Well, what we're going to focus on today is this hospital outcome piece. Everything you see here, these interactions, they all happen using data standards predominantly from HL7. So they're kind of outside of the scope of the NEMSIS data standard. That hospital outcome data, though, the idea is for the outcome data that EMS receives to get injected into the patient care report that the EMS agency sends to the state. And then that state sends the EMS report to the national EMS database with those hospital outcomes injected in. We are seeing that interoperability is happening around the country. It's still not super widespread. There's a lot of agencies just that aren't interoperable yet. Then even in those places where we are seeing interoperability, we are seeing gaps where very few records submitted to the EMS database at the national level actually have those hospital outcomes injected in. So even agencies that are getting the outcomes, it's not getting to the national database. If we look at percentages in the national database, we have made some progress over the years since we started kind of working on this effort. Less than 1% of patient care reports in the national EMS database had hospital outcomes recorded. What we were looking at specifically here is all patient care reports that were taken to a hospital or ED, and then what percentage of them had either an ED or hospital disposition recorded with some value other than still a patient. So it was very low. It has increased over the years, and last year was even higher, went up to 5%, which is cool to see. That 5% is really due to these efforts right here. Maine, the state of Maine, did a statewide integration with their health information exchange. And then last year, Florida did a statewide integration with their HIE. I can also give some honorable mentions to Wyoming and Oregon that have done statewide integrations with their trauma registries, which get outcomes on a small percentage of EMS patients. But Florida and Maine really moved the needle here nationally to get to that 5% point. If we take Florida and Maine out of the picture, then we see that the percentage of outcomes in the national EMS database actually stayed static last year compared to the year before. So in all other states, we saw very little progress. It was Florida and Maine that really drove this. Looking at Florida specifically, they were always higher than the national average, which was great. But you can see just this huge increase in 2025 when they started this statewide integration, and then even further in 2026 as it has gained maturity and become widespread. And so we're seeing just great results in Florida. Now, when Brenda talks, she's going to share how internally their numbers are even higher than this. They do have records where they have, in fact, made a match with a hospital visit record, but they didn't get the hospital or ED disposition. They got diagnoses, though, which is super helpful. So just the way we're measuring in the national database, these are the numbers we're getting out of Florida. And then Florida internally, they'll show you the numbers that they're seeing where they have actual logs of the links that they've made. They know where the gaps are and where the data is coming. And so just this huge increase. So I wanted today to be this opportunity for Florida to share what they did to integrate at the state level with their health information exchange and to get patient outcomes from the entire state into their state EMS data system. And then what they're doing to inject those outcomes into their submissions to the national EMS database, where we finally see like it gets to the end of the road and we get those outcomes in the national database. All right, so that's kind of my preface, and I'm going to hand most of the time over to Brenda, then I'll come back right at the very end. So Brenda, I'm going to go ahead and hand it over to you. Go ahead and get your screen sharing set up and take it away.
Okay, thanks, Josh. Hello, everybody. It's afternoon in Florida. I know it's morning in Utah, and I'm not sure where everybody else is, but it's really hot here in Florida, has been for quite some time. But I appreciate the opportunity today to kind of get to talk to you a little bit. Can everybody see my screen? Josh, you're seeing my screen okay?
Not yet.
Okay, let's see.
Click on screen.
I think we have it coming up right there.
That's coming up. That looks good.
Everybody
And
see that now?
I don't know
Okay, great.
Yeah, I don't know if you want your video on or off, but whatever, it's off right now. So.
Okay, I'm good with my video off. You guys saw what I look
Okay.
like. Many of you have seen me on calls before, so I'm okay with that off. I wanted to just take a minute and tell you that Florida has been in this business for quite some time, but we've just started this past year participating in sending this on to NEMSIS. And so that's why when you see some of the numbers that I'll talk about today, they'll be a little bit different from Josh. But today I wanted to just let you know, let me get my screen here positioned here. Tell you a little bit how we got started in the business of the Florida HIE, how we get our hospital outcome data, how we connect that to our EMS reports, and how we make it available to local agencies and to NEMSIS. We're still in the infancy of how do we utilize it, so I'll be very clear up front about that. We've made a lot of progress in trying to make some sense of the outcome data and how we utilize it, but I will touch on that today quite a bit. Giving you a little bit of history, Florida was very lucky in that our legislative body in 2009 established legislation to actually create a Florida HIE. Health Information Exchange were beginning to build around the country, but Florida had not gone full-fledged into that business. But with that legislation, we were able to get started in Florida. So in 2011, we actually went live across Florida. The legislative body gave the governing authority to the Agency for Healthcare Administration. So that agency had the responsibility to make sure that the Florida HIE could actually advance the use of information technology so that we could get information to the right people at the right time. So the whole purpose behind that HIE was to make sure we had a secure and reliable sharing of information throughout Florida, not only for hospitals and practitioners, but for other providers, payers, patients, anybody in the whole public agency statewide could take part in this. And its whole intent was to better give care coordination, improve, quality and safety for the patient care that we gave. In Florida, most of the submitting organizations, the data sources, were those initially and continue to be today, those hospitals and ERs who have certified electronic healthcare record systems, and the majority of them have that now. Skilled nursing home facilities that have those certified systems, adult and pediatric crisis stabilization units, receiving facilities, inpatient residential treatment facilities. And luckily, all of these type of entities were under the regulation of ACA, so it made a lot of sense for them to be some of the primary data sources. As of July 1, Florida is going through a vendor change. We had, since 2011, we've had one vendor on board providing the services for the Florida HIE. But as of this weekend, and you might have it right before you give a presentation, you go into a major transition with a new vendor. So we did. So that new vendor, I'm going to tell you a little bit about their services that they have to provide through all of Florida. And they divide those up into 4 different service areas. The last 2 are primarily implemented. The first one is the Central Event Notification Directory, and that's basically the hub of everything. That's where it's a centralized service that routes everything about the patient, from the patient's information to all the event notifications to the places it needs to go, and it receives information there as well. So that's the primary core of the HIE. The ADT, that's nothing really different from our other vendor, but that's the actual alerts. That's real-time alerts that notify providers when you have patients that are admitted, discharged, or transferred. Now, keep in mind, these can be doctors' offices that are participating in this as well, and so they want to know when their patients are in the hospitals. From an EMS perspective, we wanted to know what was happening with our patients. So this alert system is very important for us. This next service called Population Explorer, and in Florida they're going to call that Pop Action. Florida's always got to have another kind of acronym for everything. So this particular service will be the analytical and reporting platform. It's also a query platform now. So I actually could build a patient panel within that facility if that's what I had. And the last piece is what we call the clinical portal. That's going to be important for EMS because eventually that piece and that service is going to provide, for instance, like imaging, x-rays, lab reports that we're not actually getting right now, medications. We could get pharmacy data. We can also get the discharge narratives, which we're not getting. So this is the complete picture of what Florida's Health Information Exchange has to offer with our new vendor. All of this was not readily available with our past vendor, but we look forward to taking advantage of some of this. I wanted to let you know a little bit about the structure and cost because we were lucky here in Florida again in that, first of all, ACA is our governing body. They manage and regulate most of the hospitals and all of these facilities, so it made sense for the legislature to give them the authority. They also gave them the money. So that money then is going directly into a vendor contract. So the vendor handles all the money. ACA manages those contracts with the vendor. The vendor serves as that HIPAA business associate for those HIPAA covered entities that actually participate. You have no direct participant fees currently. And there's a caveat to that. Participants and subscribers, that's kind of 2 different things. A subscriber may be someone that subscribes to a service and just gets the alerts. A participant may be a data source as well as a subscriber. So right now, for the state agencies and for the majority of the participants in the Florida HIE, there are no direct fees charged. The caveat to that is, I think they're putting a cap on the number of patient panels, if you will. If you get over 20,000 patient panels, I think in a month, they may apply a fee. But right now, we are not, any one agency of ours or any one participant is not going to exceed that. So we don't have any charges that we can anticipate at all. The other key thing is that, hey, it's mandatory. Since ACA governs and manages the majority of those participant facilities, then they can require that they report. A little bit later, we'll talk about there's potentially some quality issues in terms of some of the data, but the bottom line is that they do have to report. So the other key piece that we have in Florida is what we call participation agreements. So I said ACA funds the money into the vendor contract, and the vendor then enters into participation agreements. This is a key aspect. So if you're looking at getting into the business of HIE and you have something called a participants agreement, read it very carefully. That's going to tell you what you have to do, what your vendor has to do, what your other participants have to do, and what your protections are. So within the Department of Health, we have many organizations within health that participate in the Florida HIE, but we have one major participation agreement, and then we have addendums to cover all of the different systems. For instance, MSTARS, that's our Florida EMS system that biospatial image trend is our repository. So we have an addendum to cover all of the important things about EMS. Our CHDs, our county health departments, have their own, and then we've got other registries. Our Florida Stroke Registry, our Cancer Registry, have other registries that are a part of the overall participation agreement. And the reason I wanted to bring that up and bring up how the infrastructure and how this whole thing is structured is because it's very important that we don't pay. If we had had to pay for this, we would have had many years to try to get this. So it was really key that we did not have to pay anything for this. It's totally funded through that vendor, and it's a recurring funding through the legislature. And I think it even increased this year with our new vendor. And as we go along, I'll tell you, our new vendor, as I mentioned earlier, has additional capabilities, and they have additional possibilities for us using this. And then thirdly, as a takeaway, is that it was mandatory in some cases. In the majority of the facilities that we utilize in EMS, it was a mandatory participation. So we definitely had data out there that we could take advantage of. I want to tell you a little bit about how we started into this, talk a little bit about what our project approach was. First of all, as I say, that the whole state implemented this a number of years before we got into the business. It was implemented in 2011. But in 2019, I actually was here and we started our conversations with our Florida HIE partners. And we did that because our EMS folks said, this is really great. We're submitting our data in, but it goes to this big black hole and we never really get anything out of that. So how do we know what's happening to our patients? And about the same time, you had a few agencies that did some direct connects to hospitals. And so I think Josh mentioned that. So interoperability is not the same everywhere. So you had some of your larger metropolitan areas that had more regional HIEs set up. So there was some connectivity that was established at some of the local levels. But in general, there really wasn't anything at the state level, and there wasn't any way that an agency, unless they called up the hospital to say, what happened to my Joe Smith that we took over there today. So we really wanted to push this. And so in 2020, we signed that agreement with the then vendor, which happened to be Point Click Care. And ACA, facilitated that hospital connectivity for us. EMS, of course, provided the context for us. And then at the time, it was strictly biospatial. Now it's image trend biospatial, but they served as the integration piece for our agencies, and I'll walk you through that in a little bit. Another key aspect, I think, to our approach is very clear roles. Our agency, to this day, from the time we started back in 2019, we've had once a month recurring coordination calls. That call can be just to say, how are things going? Or is there something new happening out there? Or is there something coming up? But everybody has actively participated in that. And I think it's been very good that we've had it. It's created a lot of success for us. And I think it contributes to the success that we've had. I think the other key thing, and it was called an onboarding plan. You call that onboarding when you get a new employee in, and if you're developing a system, you may call it a requirements document, but that's kind of what it is. It's kind of your plan of attack. What are the requirements to make sure that everybody understands what everybody's role is and what everybody needs to do to make it happen? And that was key for us. It laid out everything that we were going to provide, everything that we were going to get, all of our timelines, all of our technical requirements. And I think that was key into allowing us to move quickly and avoiding rework. There's not to say that you might not have some rework, because that did happen, particularly as it relates to matching. We had a lot of learned lessons there, so we'll cover some of those, but I think it's key. So if you're in that business, they may not call it an onboarding plan, but please make sure that you've got some requirements, documentation of how you're going to move forward. And then, of course, lastly, July 1. And it's funny that July 1, when our state had holidays the day before we went live with our new vendor, and the day after we went live with our vendor. So it was kind of interesting to come into work and say, oh, well, what happened? Did we work or did we not work? So luckily, our transition took place. We're still in the process of ironing out any of those kind of details as it relates to transition, but pretty much we're happy with the way things went over the weekend. In terms of how we actually started, as you know, the whole concept, and I think Josh touched on that, is the whole concept of an HIE is that you provide some patient information. So you subscribe on a panel basis your patient information from your local EMS encounters, and you try to get data back about outcomes. One of the things that we did in Florida here is that we contribute the rest of our data. So when we constructed a patient panel, we gave them some other data. So we then became a data source for the Florida HIE. So if you were a doctor and you had a patient panel out there about one of our folks that we transported to a hospital, you could actually get that alert. So we provide valuable data for those other data providers. And of course, MSTARS is our platform, and all of that is supported by Biospatial. The primary service, and our prior vendor called it ENS Encounter Notification Service. And I'm going to call it that here because everybody that utilizes the Florida HIE has been utilizing this. The Encounter Notification Service provides subscribers. That could be a doctor. That could be the MSTAR system with notifications about health encounters from our patients. That ENS service, excuse me, will get any admit, discharge, transfer notices from all of the hospitals in Florida. And I think there's over 700 that are in the list now. This might have been an old number. Excuse me. But all the other healthcare facilities that are a part of this, we will get information back if we get a match. So when one of those patients that we have receives care at any of these facilities, then the Encounter Notification Service will give you something back. I think it'll help a little bit just to show you how we operate in Florida. This is a very simplified view of how our MSTAR system works. So all of this right here is probably the same with many of you. Many of you may have just one piece of software, EPCR, out in your state. But in Florida, we have many different EPCR systems and medical devices, 911 centers that are all contributing data. You'll notice at the bottom, we also have MIH software that's contributing to our database, but all of the NEMSIS data goes into our state repository, which is maintained by Biospatial. And we call that MSTARS. We've had that name MSTARS for a time, and we hate to lose it, so we've kind of branded ourselves that. And we ask forgiveness from ImageTrend and Biospatial about that, but we call ourselves MSTARS. But that platform feeds a lot of other stuff in Florida. One of the most important here is what we call our operational data store. That is really a copy, if you will, of everything that we have in our registry, and we use that for advanced analytics that we have not implemented in the Biospatial platform. We also submit to NEMSIS through the Biospatial, and we have many other integration partners. I did not list them all here, but we integrate with Crash Data, we integrate with CARES, we integrate with the Florida Stroke Registry, with our surveillance system in Florida. So there's many things that we integrate with. But in general, that's kind of sort of how MSTARS is set up. This next slide is just going to tell you a little bit more detail about how the HIE data flow goes. So here we have EMS agencies. We receive EPCR data right into Biospatial via the NEMSIS XML, as we always have. Patient contact data. If we see a disposition where we have patient contact, we construct a patient panel. We construct a record that has that patient information as well as some other data about that EPCR, and we export that to the Florida HIE. We send that via an export facility in Biospatial that we configure to send that. And right now that is sent to the vendors SFTP and XML. If you look to the right side, all the time this is going on, you've got lots of hospitals and HIE participants feeding data in on encounters. So when our data comes in with our patient panel into the Florida HIE, they perform a patient matching, and they look at all those contributing sources over here to say, hey, do I have Joe Smith coming in here? And if I do, let's send some of that data back to Biospatial. Right now, we are not sending that back via HL7. We're because our prior vendor used CSV, we're doing this CSV, but anything that matches comes back into Biospatial. And then in Biospatial, that outcome data is attached to any of the associated EPCRs. And we do that in a couple of different ways, but I'll walk you through each part of that now. For the export, as I said, we use Biospatial's export. Those of you that are not familiar with this, but it allows you to configure all the technical requirements to move data from one place to another in whatever form you need it to be in. So any EPCR report that has patient contact made, we map that to construct the encounter data. So the format for the encounter data was provided to us by the Florida HIE. So we moved the NEMSIS fields that you see on the right into fields that construct the encounter data. You'll notice that we still have a little bit of 3.4. NEMSIS, you didn't hear that, but we still have some 3.4 data. So we also have to use and convert eDisposition 12 to Disposition 27, but we gave them the logic for that. So this is all done in near real time. So as soon as that EPCR hits and it's a patient contact, then that immediately, that encounter data record is constructed and shipped off. When I say near real time, it's as closest to real time as you can get. But as I hear, it's invalid to say real time for sure. Now we have matching. This is different than it was last week. Last week we had our other vendor, and I'll go over some matching rates in a little bit, but they do things a little differently. Chris, our new vendor, uses phonetic and probabilistic matching. They look at demographic attributes and match records to one another, and they build patient entities there. So the technical piece of that, I have a document from CRISP if you're interested in that. They allow us to share that, but basically they look for the closest match and score the top 10 matches, and the highest score becomes your match. Inpatient matching, it's all based on the demographics primarily. One thing that we sent within the patient encounter data, when we send it to HIEs, we send the UUID. That's the UUID that we get from that corresponding EPCR. So that becomes key when we get data back, and I'll mention that in just a little bit. The other thing that's key about matching is that we see this 14-day notification. We looked at our data. Our prior vendor, by the way, did not maintain historical data. So we were within the dilemma of, well, we have patients that stay in the hospital, up to 10, 12, 14 days. How do we ensure that we get all of the data about them? I want to know when they went from ER to inpatient, and I want to know their disposition all the way to discharge. So how do I do that? So our prior vendor, we required that they send us a minimum of 14 days of notifications. So we could ensure that we got everything about a patient or until they were discharged. So we're requiring our new vendor to do that. However, it's probably not as much as a requirement for them because they will be keeping more historical data. This last thing that we required, and this may not be true as you're looking at your requirements, but in Florida, we're pretty close to real time. We get 92% of our events within 10 hours. So everything is pretty timely, but we have some agencies that because of their QC process, they hold reports and they don't release them right away. So we could have the situation where we took somebody to the hospital, they're in there, we've got data there, but we don't have an EPCR patient panel to send yet. We don't get it until 3 days later. So we have our vendor look back 3 days because based on our analysis, that handles about 92% of all of our records. So that was really important for those few agencies that don't send right away. So keep that in mind as you're kind of putting your requirements together. These are some of the things that would go on your onboarding plan, for instance. The import. This is where the rubber meets the road. This is where we actually get the data. So when that match is found, we get the ER, inpatient, diagnosis, disposition. We're now getting procedures, and we plan to get other stuff. But we also getting that UUID, so we can link that to any of the associated EPCRs with that patient in the event. Right now, this is sent to us, and the vendor currently is not necessarily, it's not as real time as we need it to be because we're not HL7 yet, but this is probably going to move to HL7. Our prior vendor, this was a CSV solution, so to ease the transition to the new vendor, we left it CSV for now, and we probably will be moving that to HL7 in the future. And as I say, this is all stored on biospatial. Now, currently, we have like a 74% match. That's why Josh said, hey, it looks really different than what the national looks. So one of the things that to keep in mind is we started collecting and participating in the Florida HIE several years before we started sending data to NEMSIS. So we're going to have to reconcile that at some point in time, but right now we still have not caught up with where we need to be. When we look at this 74% match rate, this is inclusive of two different kinds of outcomes that we're getting. Currently, we have the Florida HIE, and we also have recently, in the past 2 months, Image Trend has implemented Caralytics, which is a product, and I don't know that much about it, but I know that it is providing the service for their HCA partnership. So HCA has they have a tremendous number of hospitals here in Florida. So that linkage is in this percentage. So you see both of those, the true HIE and the true HCA linkage here. That's why you can see for many months we were in the 63, 68, 69, and we started bumping up when this was implemented. So our true through HIE is probably more in the 65 category. So we'll try to shore that up a little bit and try to distinguish the difference in those in future reporting. So when we first of all started, we were like at 35%. And our biggest issue there was demographics. But in our most current analysis, our demographics, we're looking pretty darn good. Our demographics that are the elements that are primarily used in matching is our name, first and last name, gender, date of birth. The only thing that we've still got issues with, and you probably do too, is Social Security number. We just don't have a good way of assuring the collection of that because many of our patients can't give us that, and many of our patients are not identifiable via Social Security number when we pick them up. So all in all, we're pretty happy with this, but I think what we did early on was we did some analysis on this and we did a lot of cleanup. We had a lot of data missingness. We had a lot of data incompleteness there. So you might have a first name and you didn't have the last name. You might not have had the date of birth. So a lot of that we tried to clean up early in the game, and that's why we kind of attribute that to getting a better match. There's another element that was used by our prior vendor, and that's facility. I don't know about you guys, but facilities can be kind of tricky because they can be called many different things. They can be called one name on a licensed database, and then the agency may call them something else. So it was really kind of interesting to get facility right. So when you look at facility type, we tried to concentrate on getting facility type correct, so that could be used in matching as much as can. So we're doing pretty good there in 26 so far. We've only got about 17% that's not accurate there, but that's another area that we're going to be cleaning up. So when you start out in the business with your vendor, understanding truly what they use for matching is going to be key, because we had a lot of cleanup up first because we just jumped into the fire and really didn't do a lot of analysis on how good the data was that we were going to send for matching until we got back very few matches and we thought, oh, I think we have a little problem here. So we did clean that up. So that's one of the things you can do early on is try to look at what data you have and how you could get that cleaned up before. Outcome from multiple sources. Yep, we get it. Agency can populate the e-outcome field. That takes precedence over everything. Here, again, you see that we've gotten HCA outcome. If an agency doesn't give us outcome data, then, and we get it from HCA, then we'll put both of we'll put that HCA in the e-outcome fields. The HIE data, however, is stored separately. We do not put that in the repository outcome field, so that's a little different. We have a lot of planned integrations. We have our ODS here, our operational data store. We have a project in progress where all of the HIE outcome data is going to come down to our operational data store. That's going to give us the opportunity to integrate with other data sets that we have direct control over, the Florida Stroke Registry, the Trauma Registry, CARES. So that's just another planned integration that it's important to know that all of those have outcomes. So who's got the right outcome? So it's going to be an analyst's dream to kind of look at all the different kinds of outcomes and try to make some sense of that. So we're looking forward to that. The export. This one is what we started, I think, last year. Um, Steve McCoy came into my office and said, "Why are we not sending outcome data to NEMSIS?" And we're going, "Well, we don't really have very much. All we have is HIE." So guess what? That's what we're sending. So if the e-outcome fields are populated either by an agency or by HCA, we send that to NEMSIS. If neither of those exist, then we send the HIE outcome data to NEMSIS. So that's one of the things that's a little different there that we were not sending before. So it's made a lot of difference. So I'm going to try to just kind of, I know what's our time? We got about 15 minutes. I want to talk to you a little bit about what we're doing with this and how we see it. As I said before, many people in Florida are trying to get to their outcomes, and very few have direct access via the hospital. So we utilize biospatial. We mentioned that we had a high current match rate, but guess what? Sometimes that match report doesn't have an outcome data in it. So when we send our stuff to NEMSIS and NEMSIS is looking for outcomes, it didn't have one. So that means that the hospital didn't send us that. So we also have to really watch that. So we may have diagnosis, but we don't have disposition. This little chart over here on the right shows you that in the case of March, we had 65% matches for HIE, but 80% of them had hospital diagnosis, and only 53% of them had disposition. And then we had 14% that didn't have either. So that's data that's not coming from EMS. That's data from a hospital. So that's data quality issues that have to be addressed by your data sources that we're working with ACA on. Sometimes we get a match report, but the diagnosis is different from the hospital and EMS. This is where we find an opportunity, and we see this outcome data that's coming to us, and we can identify when we're different. So in this particular case, and we've used this already, we've looked at how these things are documented, and a key reason for some of this happening is that we're not coding all the NEMSIS fields. So we may be coding primary impression and not secondary. And so those are things that indicate that we may need to strengthen, our syndrome identification. We need to align properly with the hospital diagnosis. We need to have training in how to better document some of our reports. So how do we see it? I don't think we're going to have time to do a biospatial demonstration, and to some of you it would not make sense, but I do want to flip through these fairly quickly in that we see everything in biospatial. We have an advanced search that we do. When you get to biospatial and you see, this is an actual EPCR, and you can see, we can actually see what EMS called a primary impression, what the hospital diagnosis code was, and what the disposition was. We can go down into more detail and actually decompose and go down into that record. So if I clicked here in biospatial, I could actually see the event record if I wanted to. And then when I got to the event record, here is what you see in biospatial for the linked hospital data. You see the disposition, the diagnosis, if it was there, and any relevant hospital records. This little button right here actually will show you those records. So you can see when everything about that patient, when they were in, if they went to the ER, when they got transferred from the ER to the inpatient, and everything that happened to them in between. What do we actually do with this? We're learning. We're learning a lot what to do with it. Primarily, our intent is to use this data for quality improvement of patient care delivery. That's the bottom line. We want to look at true patient outcomes. We want to see whether or not our patients survived, how they recovered, were our interventions correct, and do we need to refine protocols with what's happening locally with our linked data. and we want to be able to measure. We've got lots of national measures that we're looking at. And then also assess our data completeness, missingness, and correctness. So that's primary goals. One of the things that we have implemented, it's just brand new in biospatial, is looking at pure outcomes. And this, I'm going to look right here at stroke outcomes. So this intent of this outcome, so we're building these measures to look at the outcomes. This is the correctness of identification of a stroke. How correct was our stroke identification? It assesses the agreement between EMS suspected stroke and a hospital confirmed stroke. So if you look and apply that filter in biospatial, we can actually look at that. And this happens to be just an example of 1 quarter for one EMS agency. So we had pre-notifications. We called the hospital and said, hey, we're coming in with a stroke. We took them to a stroke facility, but oh goodness, over here, we don't have a really high agreement between EMS suspected stroke and hospital confirmed stroke. Now, there are lots of reasons for that, and that's what analyzing your outcomes are all about. You can't just take a number like this for just straight value. You actually have to look at it. Remember here, this slide, we said, hey, sometimes the diagnosis is not recorded properly. That could have happened in the prior case. So you have to actually go down and look at what is being recorded. So you can go into our system and you can look at any of the diagnosis codes. So this is a pure example of how we're actually using that kind of outcome and say that stroke outcome when what did EMS call if they didn't call a stroke? What did they call and what was missed? So this is the perfect example of how outcome data is a training signal. It's exactly where you need to be training your teams out there in the field to, or changing your protocols a little bit. Sometimes we are possibly recognizing some kind of dizziness in the wrong way, or we need to look at headaches differently. So this is the opportunity that looking at outcomes, whether it be disposition or diagnosis, can help us. This is another big thing I want to hit on is that we have big plans for HIE and mobile integrated health. We're just getting into the business of this, mobile integrated health in Florida, and we see the potential there. You have MIH service delivers within our EMS agencies, and they need to see what's happening with their patients locally. So we currently can see in biospatial, if they have coded their type of service as mobile integrated health, I can see all the linked hospital data, but the vision that we have for MIH and outcome data is more of those other local mobile integrated health service providers and connecting those locally with our EMS mobile integrated health service providers. So we think that is a great potential. We've got a lot of other use cases. Our CARES coordinator now looks at discharge status, and that helps them determine whether or not they can look at the MRN and go directly into the medical record to do any cross-referencing they need to. The EMS agencies right now are looking specifically for quality improvement on provider impressions versus hospital and discharge impressions, as I mentioned to you earlier. And we have a lot of partners, for instance, our Florida Stroke Registry, looking at reviewing quality from dispatch to discharge. So the number of things that you can do with HIE are just as the number of people you can talk to, because everybody has a different idea. I'm going to try to go through this real quick in case we have a few questions. Insights, early involvement. Identify those use cases earlier. We didn't necessarily do that. We jumped in and went head first into it. Start early with connectivity and onboarding requirements. Make sure everybody knows what you're trying to do and get all your technical requirements together. Ensure your data is ready. Go ahead and look at what your matching is going to be and try to get anything cleaned up that you can early on. Test it. Make sure you've got accurate and it's useful. Understand the clinical workflow and test your use cases. Make sure it's beneficial. And then build stakeholder awareness. This is kind of where we are right now. We have we've told everybody we have it, but I'm not so sure we did a great job on showing them actually how to use it. So that's what our emphasis is this year, is putting those use cases out there and then show them actually how to use it. So it's always improving. That's what we try to do every day. We got just a few minutes for questions here. Josh, I'm not sure how you want to handle it. It took me a little longer than I thought, but I get wordy sometimes. I'm sorry, guys.
That was great information, Brenda. Thank you so much. There were a bunch of great questions that came through the Q&A that I hope I was able to answer based on my knowledge, but there were a couple that I didn't know the answer to. One is looking at who can see the outcome data. Oh, and Brenda, you might want to stop your screen share. Your PowerPoint went away. Who can see the outcome data at the local EMS agency level? So it sounds like administrators can. Someone was curious if individual EMS providers can also access that outcome data.
It all depends on how their biospatial access is established, and agencies themselves create their own users, and so they can establish and give that access authorization wherever they choose. We don't
Okay.
control it locally. The administrator of that agency does.
Okay, thanks. And another question I didn't know the answer for, you were looking at the match rates for EMS patients and what percentage of them got a match with a hospital record. Someone was asking if you know what the general match rates are for other kinds of providers in the HIE. I guess kind of comparing like how are we doing in EMS compared to everyone else who participates in the HIE in terms of patient matching?
I think that's a great question. I'd like to follow up on that. I've not asked them. We actually have a unique situation. Most of the participants in our agency don't actually send patient panels like we do. They just receive alerts on anybody that's in their system. They actually send a whole list of patients. They send like a roster, like annually. And I don't really know what that is, but it's a good question. I'll follow up and try to give that back to you.
Okay. And lastly, there are some agencies you mentioned they already had a one-on-one connection between their agency and hospitals that they served. So they were already sending some outcomes to your state, perhaps. Did you see any agencies kind of like shutting down those local connections that they had because of the fact that they were able to get the outcomes through your state level integration, or did they keep those local integrations in place?
Because of HIE, but because
Hold on. I have not seen any of that. But there again, we have not done that detailed analysis on that to see whether they've shut them down.
Okay. Yeah. Yeah. One of the things I mentioned in one of the other Q&As that I answered was, this data is coming from the HIE back to the state EMS data repository. It's not going to local agencies' EPCR systems. And so then, as you mentioned, Brenda, agencies can give web-based access to their employees to go into your biospatial platform and see outcomes there. So there's still a role for getting outcomes at the local level and getting those data actually, into that EPCR system. And what I'm kind of watching around the country is that we do have integrations happening at the local level. And many of those, though, are not actually sending the outcomes to the state, and therefore they're not going to the national database either. And I think in an ideal world, we get the local agencies getting those outcomes in their EPCR system, and that those outcomes get to every other system as well. And that's what we need to see happen. And this is an interesting alternative model here where Florida says, hey, we can just integrate with the HIE at the state level and get outcomes on so many patients so efficiently. So it's a really cool approach that you've taken.
However, we want to do more. We are in discussion with ACA and our new vendor because there's a possibility of one of their product offerings that our local agencies can go directly into their portal and see the data there as well. So there are some alternatives, plus there's some other data that we're not. For instance, the state really does not want to keep all the medical records, all the medicines, and all the labs of a patient, but my local EMS agency that has an MIH program may want to see those labs. So there is a real reason to integrate for MIH reasons. So we're looking at doing more there. Thank you
Yeah,
guys for having
interesting.
me.
Absolutely. Thank you. Hey, everyone on the call, if you're getting outcome data and you want to know if it's getting to the national EMS database or not, you can contact me and I can check at the individual agency level or the state level. And if the outcome data is not getting there, then we can work on plugging that gap and fixing that gap and verify that the outcome data actually gets to the national EMS database. Lastly, I'll leave you with this link on the NEMSIS.org website. If you go to the Using EMS Data menu, you'll see a page called Interoperability, and that's a great launching point for everything related to EMS data interoperability. I am available to help and assist as you work on projects and you need a little bit of like strategic direction or technical guidance or whatever else. Then feel free to get in touch with me and through my work that I do as a contractor to the NEMSIS TAC, I'm happy to help you with those things. There were a couple other questions I think we didn't get answered, but I know we're about at time. So Chris, I'm going to hand it back to you.
Perfect. Thank you so much. And big virtual round of applause for our guests today. It was great information. Also, one last plug for following along with the NEMSIS TAC on social media. Look for NEMSIS TAC on your favorite social media site or sign up for the mailing list by going to nemsis.org and then clicking at the bottom to open a ticket and add yourself to the mailing list. Awesome. Thank you so much. Thank you, Josh, and thanks our guest Brenda. This is great information. Like you said, you had your contact information. Also, if they have a question about this, you can also utilize the ticket system on the NEMSIS website. Go to the bottom, click on a ticket. We will get that information over to the best person for you. If it is Josh, we'll get it right over to him and he'll get in touch with you with a great answer. So awesome. I hope everyone has a great rest of their day and we will see you next time.